Okay, welcome everybody. My name is Rachel. I'm one of the site engagement coordinators with MVC. Thanks for joining us today for our sepsis work group. Um, Today we are going to be going through some housekeeping and P4P credit reminders. We will have a presentation from Covenant Healthcare on their sepsis initiative. Oops. Ignore number 3. I meant to delete that. And then we'll go through some discussions and questions that you guys might have after the presentation. And then we'll share some MVC updates and upcoming events. So some of our housekeeping reminders is that we'll be recording. So please make sure that you have your microphone muted unless you're asking a question or, a part of the discussion time. And that helps reduce any background noise we might have. We will also be sharing the presentation slides and recording with the attendees. After the work group is completed, that'll come out via email, and then the recording is on our YouTube page. And then questions, we'll be monitoring the chat throughout the presentation, so feel free to put them in the chat as things are going through, and then at the end we'll bring them back up and talk about them. So P4P workgroup credit reminder for those attending the workgroup for P4P engagement points. We look forward to having active participation throughout the workgroup. So that includes, responding to any discussion questions or asking questions that you might have after the presentation. And then at the end of the workgroup, we'll be sharing a link to our post-workgroup survey. For P4P credit, you will need to complete the survey for your site. Just a reminder that one survey per person per site should be completed for that requirement. Today's presenter is Amy Lorenz from Covenant Healthcare. Amy started at Covenant Healthcare in April of 2014 as a case manager, utilization specialist, as well as a nursing home placement specialist. She started in patient safety and in the quality department in November of 2019 as a sepsis abstractor, and then later as a sepsis leader in February 2021. Amy will be joined today by some of her colleagues, Seth O'Brien, who's the IT coordinator for inpatient and HOD, Beth Turnbull, lead senior EMR applications analyst, and Drake Horton from Epic Technical Services, working in inpatient orders. They'll be helping field any questions that may come up after the presentation. Welcome, Amy and your team. I'm going to go ahead and pass the baton over to you, Amy, now, so that you can dive into the presentation portion of the work group.
Thank you, Rachel. Again, Beth Turnbull is our lead senior EMR applications analyst. Seth O'Brien is our IP coordinator, and Drake Horton as well is our technical services for inpatient orders, who will be also joining us today. Next slide. I wanted to give a little bit of historical data as to what predicated investigation, research, and validation of predictive model and BPA alert reviews. 2021, we had a CMS compliance score of 64%, with a total case review of 728 for that year. In 2022, 69%, cases 806. And in 2023, predictive model went live towards the tail end of Q3 of 2023. So you see a little bit of improvement, 76%, with cases reviewed 683. And in 2024, we see a jump. Predictive model was live. And we also went from full abstraction of all cases to sampling, which is why you see a lesser number for the total cases reviewed, with an uptick of 84% for our CMS compliance score. And I have 2025 out there just as reference. We're at 82% for total cases reviewed, 83. And I just have a little bit, I showed a little bit of a chart here to see the incline all the way to 2025. Next slide. This shows, this is the blue line represents Covenant Healthcare, and you can see 2021 again representing the percentage of how we were doing. And if you look towards August of 2023, tail end of Q3, we see an improvement. And this is a comparison with Covenant compared to other core hospitals' performances. From January of 2021 to February of 2025. Next slide. So this is the number of our practice or OPAs. To give a little bit of data, as you can see, predictive model, Q1, Q2. We had this running in the background with no restrictions, no exclusions, just collecting data, total data. With it running. The modified SIRS for Q1, Q2 was the actual alerts that were being sent to the nursing and physician staff. Q3, again, tail end, we went live with predictive models, so right around August, September of 2023, and you can see the modified SIRS were still running, but you see a decline, 1,607 for predictive model, which means that in a few slides ahead, the exclusions or criteria was applied to get a more finite and a more accurate representation of sepsis patients. Q4, modified SIRS was retired, and as you can see, from 35,854, 36,006, 28,231 alerts, we went to 1,496, 1,397, and so on and so forth. Very accurate data, which has led to the improvement of our CMS compliance scores, as was represented, because we have a truer picture of the sepsis patient with exclusions applied. Next slide. This just represents, we had a reduction in our average BPAs. They were around 90 to 100,000 that would alert, and it's an interruption to your daily flow. And it's declined to 30,000 interruptive BPAs per month. The orange bar displays desired action numbers, not percentages. We have successfully cleared out huge numbers of inefficient extra alerts while maintaining needed actions. We went from a 10% action rate to a 24.5 action rate because the data is so finite and the alerting of sepsis is a more true picture, more valid data. Next slide. These were the exclusions that were applied. Predictive model was running Q1, Q2 in the background with no restrictions, no exclusions. And this is an example of the exclusionary criteria, such as over the age of 16, excluding patients that were comfort measures, positive COVID, or already being treated for sepsis, antibiotics, lactics. These exclusions were applied to after predictive model was running in the background Q1, Q2, and towards the tail end of Q3 to give us the more finite and validated picture of a sepsis patient. Also, the verification that the correct treatment team is evaluated. Next slide. So the modified SIRS criteria you'll see is all zeros. And what this represents is orders placed from alerts. Before predictive model, the nurses were not allowed to place orders for lactics and blood cultures based on the alerts with the modified SIRS criteria. After the adoption and implementation of predictive model, you can see that our nurses were able to enter orders for lactics and blood cultures based on that alert. Our leadership team approved this, the ability for them to place orders based on that alert, because the data was validated and it was very finite and it seemed to really represent the true sepsis picture. The total is the total number of patients. Um, in some cases, the treatment team would be allowed to select an acknowledgement reason and then later returned to do an action, whether it's the second or the third alert that needs to be noted. Next slide. So this gives a better representation of predictive model versus modified SIRS. Quarter one, quarter two, and the tail end of quarter three, predictive model was running wide open with no exclusions, no restrictions. Modified SIRS, this was an actual, these were the alerts, 35,854, 36,006, quarter one, quarter two, and towards the tail end of quarter three, 28,231. With the retirement of modified SIRS and the implementation of predictive model going live, the tail end of quarter three, going into quarter four, you can see the deep decline of the alerts from 35,854, for example, to 1,496. This also alleviated a lot of caregiver fatigue. And our staff was actually really happy to see this be rolled out. Next slide. So with the modified SIRS criteria, we were having 35,355 alerts and overrides. In comparison with predictive model, it was 1,483 with chart review, immediate retrigger, 596. Does not apply. They would actually have to put in a comment, 439, as to why this was being overridden. And actively treating sepsis was 236 versus the modified SIRS, 35,355 alerts. I'll be back, reopen the chart to trigger, 29,751. And I do not suspect infection, 5,604, which traumas, GI bleeds, these tend to mirror sepsis, but may not be sepsis. So this is just a representation or a comparison of the modified SIRS before it was retired versus predictive model. Next slide. Okay. This just is a good representation of quarter one and quarter two. Modified SIRS was running as normal with alerts 35,854, 36,006, 28,231. And again, predictive model went live tail end of quarter three. Now the numbers for predictive model, again, quarter one, quarter two, and the tail end of quarter three. The reason why they're so expansive or large is because there were no exclusions or restrictions applied. It was running in the background for data validation to take a look at what actually was going to pull. So the modified SIRS is retired and the predictive model is the current alert. Next slide. Okay. So final thoughts on this. Our Covenant IT team, they're instrumental and very important to this process. They continue to monitor the function and performance results of this early sepsis predictive model BPA, and discussions are introduced if revisions need to be examined and/or changed. This is an ongoing process with this review with our IT team. The implementation of early sepsis predictive model has lessened caregiver systemic fatigue. It allows for a more precise acknowledgement reason by our staff, nursing staff, physicians for selection by the sepsis care team, and it is reviewed ongoing by our IT team.
All right, we'll open it up to some discussion and questions if anybody has any.
I have a comment and then just a quick question. So, Amy, this was really great presentation, very helpful. I think you're addressing a lot of issues that a lot of folks on the call have had to face. One thing that came to mind as you were talking about the alerts and kind of changing, making them more appropriate, more reliable. Kind of made me think about folks on your team having to deal with alert fatigue and all of that. Was anybody tracking at all, like staff satisfaction with documentation or just in general? Because with the nurses now being able to do some ordering and stuff, have you guys seen any change in any of that? piece, or is that something you're still looking at?
Well, I think my IT team can answer that, but I can answer from the beginning. Just hearing the positive feedback from nursing, they were very happy about this because I believe with all of the alerts, they were honestly glossing over and choosing to come back to it later. And I believe that the glossing of over it becomes a habit over time. So I think this was actually a really good implementation so that it does lower or lessen the amount of alerts, and it's a more proactive approach to an actual sepsis patient.
Yeah, I can speak to that a bit as well. We heavily involved our nursing leadership from the get-go, letting them know that this was available, involving them in the data tracking process. Once we went live, I would provide weekly reports on the comments that their nurses were leaving. So this doesn't apply, for instance, because the patient is comfort measures only. Well, that was a great comment. So we excluded comfort measure only patients. Or these are our COVID patients. We have completely different criteria, parameters, et cetera, excluded our COVID patients. So nurses had an open forum basically to comment back. They were incredibly happy with the reduction in alerts. And then also with the ability to provide their inputs as to how we could more precisely target this. And it was a really great collaboration across the board. So a lot of satisfaction there.
That's awesome. Thank you.
Mm-hmm.
Questions in the chat. Amanda Zimmerman asks, which predictive model are you
Rachel, your sound is down. Sorry. I can read it off if you want.
Yeah, that'd be great.
Okay. Amanda Zimmerman was asking, which predictive model are you using? Second question, are you using the 2.0?
Version 1. So yes, the BPA, we have a question there. Does the BPA link to an order set? We actually decided to do direct orders. So I can probably throw a screenshot in there maybe. It directly links in the lactic order serial and the blood culture as well. So they can choose one or both without having to open to an additional order set and then pick which one, et cetera. So what was the overlap between the cases for which the new predictive model alerted for possible sepsis and the cases that were ultimately diagnosed with sepsis? We do have that data. So when we went live with this, we sent out a tip sheet letting everybody know the efficacy. So the SEERS criteria for our alert was 9 to 18% accuracy rate. When we went live with this alert and tracked the data, we ended up with a 50 to 60% accuracy rate. And how we measured that was by the end of the patient's encounter, once coding was complete or so on, did they end up with an active sepsis diagnosis on the chart or not? If they did, we counted that as yes, this was an accurate trigger for a patient who did end up being diagnosed with sepsis. If not, then we did not count it, whether or not there were notes of possible sepsis or anything else. It had to be an actual diagnosis placed on the chart. So ended up with 50 to 60% accuracy based on the month or the week that we were tracking and trending versus the 9 to 18%. So a huge increase in accuracy.
There was a question that came through, and I'm not sure if you guys can see it too. The question being that could you just explain the predictive model a little bit? They weren't sure exactly what that is at your facility, and also commented that it's not everybody's on Epic, so it might help a little bit to understand more about what that means in the Epic system.
Is Seth on? If not, I can chat about it. Okay, so the predictive model is kind of like a scoring system, if you're familiar with those, or a rule-based piece of logic where it looks at a lot of various criteria. Now, this is from Epic. It's Epic released, and then we added our other criteria. So, for instance, make sure the person it's being triggered to is on the treatment team, make sure it's not comfort measures only and things like that. But the predictive model looks at a wide variety of things. Let me pull up my screenshot again. We've got a tip sheet that we sent to our nurses that we can send out to the team here as well that I think might be helpful. But for instance, it looks at the number of active medication orders that indicate risk. So cephalosporin orders, as an example. It looks at procalcitonin or neutrophils, lymphocytes, so different lab results. It looks at age. It looks at other comorbidities such as diabetes, chronic kidney disease. So it has a large number of criteria that are known to impact whether or not a patient is going to end up getting sepsis. And then it also combines that with the traditional SEERS criteria, so their various vitals, and then uses that to say this patient, based on their risk factors and their current vitals and different lab values, is at high risk for sepsis. That helps.
Awesome, thank you. We have another question from Liz Lufer. Have you done a review to see if patients are being diagnosed with sepsis who the predictive model didn't catch? Just curious because of the huge drop in numbers from the non-specific SERS model.
We did. Amy, do you want to chat about this or do you want me to?
Please go ahead, Beth.
Okay, so we actually ran this data both prior to releasing and then afterwards. We wanted to make sure that we weren't releasing a data model that was going to reduce our nurses' burden, but then increase risk for our patients. And time again, we saw that overwhelmingly, because of how well this predicted sepsis, that we missed on average per month 1 to 2 patients. Versus the SERS criteria, even though it triggered so much, it still ended up missing significantly more patients than this predictive model. So while I don't love that 1 or 2 patients do not get the trigger, the risk versus benefit far outweighed that, because the other triggers were, even though they were triggering so often, still missed patients. And additionally, because of alert fatigue, like Amy was talking about, the alert was very, very often ignored because it fired so much. And so it lost its significance. People just saw it and they're like, yep, that's firing again. And then they would dismiss it, versus this one, they actually take time, they consider, they evaluate their patient, and then they place the orders as appropriate.
Okay, so I have a question for Amy and the team. Excuse me. What recommendations do you have for a site or a system that is looking into update their sepsis alert program to boost compliance? Were there any barriers that you think people should be aware of, or things that worked really well for your site?
I'd like to comment just on the validation portion. Beth and the team ran this behind the scenes for Q1, Q2, and possibly even longer, part of Q3, just to collect what wide open, without exclusions, what appeared or was reported before ever applying any exclusionary criteria. And I think that was that was the most productive and the best way to handle it, to actually get a core group before exclusions, and then look at what numbers do we end up with after those exclusions were applied.
I think another thing that really helped was the heavy involvement of our nursing team and our provider team. First of all, giving them a voice. People are much more likely to respond well if they feel like their knowledge and their inputs matter. So providing that data to them ahead of time, letting them gain confidence in what they're seeing, letting them tell us, well, this is not appropriate because X, Y, Z, and then accounting for that. So that heavy involvement and then conversation that went on really, really increased compliance and adaptation. Everybody was excited for this. which is not always common when you have a new alert coming out. And they were very excited for this. So I think it's just that collaboration and involvement and the intense amount of data ahead of time that really provided that confidence.
Awesome. Thank you so much. I think I missed a question a little earlier from Abby West. Kind of hop back here. She wondered what the overlap between the cases for which new predictive model alerted for possible sepsis and the cases that were ultimately diagnosed with sepsis.
Yeah, so that was what I chatted about a bit earlier. And then the question right here that we just got, it sounds like there's still 40% of patients who are ultimately diagnosed with sepsis. I think I presented that or explained that incorrectly. So when I say to 50 to 60% accuracy, let's pretend that this triggered on 100 patients. 50 to 60% of those patients ended up being ultimately diagnosed with sepsis. So there are 40 patients that it triggered on saying this might be sepsis, but it wasn't because it was heart failure or it was something else like that. And again, before it was 9 to 18% accuracy rate. So it triggered on 100 patients, but only 9 to 18 of those patients really ended up with a sepsis diagnosis. So we are missing patients that do end up with sepsis that the OPA or the BPA does not see 1 to 2 a month. Don't love that, but much, much better.
All right. Well, thank you so much.
Absolutely.
I do have a question for the group. We'll see how chatty people are feeling. I was just wondering if anyone on the call has implemented a similar sepsis alert initiative, and if so, what kind of results your site has seen. Yeah, feel free to put responses in the chat or unmute.
Hi, this is Julie from Marquette. We are actually piloting something called Palantir, where it takes some of the search criteria, it uses AI, and it looks at some documentation and imaging results and other things, and it narrows it down to kind of do the same thing. Weed out all the sepsis alerts because we're finding the same thing. Everybody's flagging for sepsis, and so it's just kind of getting ignored. And we're in the trial stages of it. We're just trialing it in the ED, but we're finding that we're getting a lot less sepsis alerts, but they're a lot more accurate. And so they're getting taken more seriously and patients are getting treated. So it's very exciting to have that.
Awesome. Thanks, Julie. Do you mind putting the name of that in the chat?
Sure.
Thank you.
Thanks for sharing that too. And we'll look forward to following up with you later on how that goes, because that is really exciting. I love that you guys can pull in some of the imaging as well. That's so important.
It looks like Corewell Health uses Epic Sepsis OPA version 2, and they're in the middle of testing and adjusting the thresholds. Awesome. Thanks, Christina, for sharing.
Sure. Interesting enough, through our testing, we just presented at Epic at the XGM conference. And through the testing that we had already done, because we're not complete yet, we did find that our setup and where our thresholds are now, the OPA actually works better in our emergency department, where we don't have it actively running. But the testing shows that it would work really well there, that our accuracy for our ICU is about 1 in 4 patients. So some a little bit of tweaking left to be done and some more testing, but looking promising.
Awesome. Thank you for sharing. And it looks like Aaron from Bronson uses Epic Sepsis version 1, but we're moving to version 2 in Q3. All right, cool. So hopefully you see some similar positive results there. Okay. Looks like hold on. Jennifer writes in that the BPA triggers to the RN when Epic looks in the background predicting sepsis. The RN opens the sepsis screening and assesses the patient. Then the BPA fires every 15 minutes until a screening is done. Okay. And then we've got Hurley implemented NEWS criteria, NEWS, within a new nurse-driven care path for the emergency department using Epic. Do you mind, Julia, do you mind talking about what that is, the NEWS criteria?
I was just going to ask that same question. I'm sorry if
If you're able to. If you can't talk on a mic, that's fine.
Did I unmute, hopefully?
Yes, I can hear you.
Okay, sorry, my air conditioner's on. It's a new early warning system is the acronym. So I don't remember the specific criteria. Unfortunately, there's a lot of people on the team and I kind of oversee making sure we're making progress on it. So I don't remember the specifics, but it's probably pretty well published, I would imagine. NEWS criteria.
Thank you, Julia.
Yeah, widely used deterioration index, including, it's not SIRS necessarily, there's a couple of other things, and then our physicians, our emergency room physicians made modifications. But the thing that was new for us is this is nurse driven through the care path model in Epic. And so they get the BPA and consider the patient part of that. And we just started it in February, so not everybody's on board with nurses having that. Not everybody's on board. Everybody's on board with doing it. It's just it's taking time to integrate through, and actually, so we're not really seeing results immediately from it.
A lot of times it does take time. We had a couple more comments in there too.
Yeah. It looks like Erin has a question for Amy. Is your BPA used in the ED setting or just inpatient?
It's used in the ED. Approximately 94 to 95% of our patients that come through the door, that's when sepsis is alerted or diagnosed. So yes, our ED is definitely, that's where it starts. So yes, it is used.
Okay, awesome, thanks. Jennifer wonders how the BPA will predict for older patients that fall at home and are on blood thinners, or if it's like a trauma activated and they're admitted to the hospital and then get a diagnosis of sepsis.
I don't believe that looks at it does look at their medication list, whether that's prior to admission or active inpatient. And trauma is also not an indicator. So like a level 1 trauma, level 2, et cetera. I don't believe those are part of the predictive model. Once they do have a diagnosis of sepsis, the alert stops triggering. But again, it does look at comorbidities, medications, and age. Age is also a factor as well. So partially answer your question.
All right, Stacy says Henry Ford Jackson has a suspected sepsis OPA based off a risk model and an OPA that fires based off 2 SIRS and OD. They also have a nurse-driven ordering protocol when these OPAs fire. Thanks for sharing, Stacy. All right. Well, any other questions or comments? Maybe give people a few more seconds to chime in. All right. Yeah. Thank you, everyone, for sharing and asking such great questions. This has been a really great discussion time. We're going to kind of move on now towards our MVC information to keep you all updated. We have upcoming work groups. So for this month, we have a health and action work group on May 29th, which is a Thursday. And that work group is going to focus on an early ambulation initiative and M2C2 care path at Michigan Medicine. And then on June 10th, we have our cardiac rehab work group, which will highlight how hospital organizational structure impacts cardiac rehabilitation. And then if you missed any of our last work groups, you can always read the highlights in our blog that is on our website. Those will be available, I believe, mid next week for the April work groups. The earlier work groups are already posted on the blog. You also get them, I think, in the emails that get sent out if you're subscribed to our newsletter. Upcoming events. We have our MVC site visit sign up open. We would love to coordinate with your site or your system to do one of these site visits. It's a great value add for both the sites and for MVC. You get to kind of take a more in-depth look at claims data for your site or system and work together and see each other either in person or we can do it virtually. The link will be on the slides that I email, but it's also posted, I believe, on our website. Anybody who is involved with our P4P program, our Q1 reports will be sent out this month. The final date has not yet been decided, but it will be this month. And then upcoming in June, we have our MVCQI survey that will be coming out. And this will be another opportunity to earn engagement points for your site or system. And then finally, calling for presenters. If you have an interesting initiative that your site has been working on, or you have some really great data that you'd like to share or tools that you'd like to share with our members, we'd love to hear about it and see where it might work, either as a work group or maybe a virtual networking event or our collaborative wide meeting in the fall. So that link will be on the slides as well, and it, I believe, is also on our website. So feel free to send in any ideas you might have. And that is it for today's work group. Thank you, everyone, for joining us. Thank you, Amy and Beth, for all of your expertise and sharing all of that information and great work you guys are doing. And Emily is going to be sharing our post-work group survey in the chat for the P4P participants to fill out for today's work group. Thanks a lot, guys. Have a good day.